What are the key differences between delirium, dementia, and depression in the elderly, and how does this distinction impact your nursing assessment?
Differentiating between delirium, dementia, and depression is arguably the most critical clinical skill in geriatric nursing because these conditions often present with overlapping symptoms in the elderly, yet demand vastly different interventions. The failure to accurately distinguish them can lead to significant morbidity and mortality. The key difference lies in the onset and course of the cognitive change. Delirium is an acute, sudden change in attention and consciousness, fluctuating throughout the day. It is a medical emergency, often triggered by an underlying physical illness like infection, dehydration, or adverse drug reactions. In contrast, dementia has an insidious, chronic onset, marked by a progressive decline in memory and executive function over months or years. Depression presents as a sustained low mood, lack of interest, and sometimes difficulty concentrating, but the level of consciousness remains clear. This distinction profoundly impacts the nursing assessment. If I suspect delirium situation, my immediate task is to identify and address the underlying cause. My action involves using a validated screening tool like the Confusion Assessment Method, CAM, followed by a rapid, focused assessment for causative factors, checking vital signs for fever, reviewing recent medication changes, and testing for infection. The result is often the reversal of the cognitive impairment once the infection or electrolyte imbalance is treated. If the presentation is gradual and stable, suggesting dementia, the focus shifts from urgent reversal to long-term safety planning and behavioral management. If depression is the primary concern, the assessment focuses on suicidal ideation and initiating mood management protocols, often involving social workers and physicians. The clear differentiation between these three syndromes dictates whether the nursing response is an emergency medical intervention or a long-term psychosocial care strategy.
Describe the common challenges of polypharmacy in older adults. What steps do you take to prevent adverse drug events?
Polypharmacy, commonly defined as the regular use of 5 or more medications, presents significant and complex challenges in older adults due to age-related physiological changes. The primary issues stem from altered pharmacokinetics and pharmacodynamics. Decreased renal and hepatic function prolongs drug half-lives, increasing the risk of accumulation and toxicity. Furthermore, multiple medications raise the likelihood of adverse drug reactions, ADRs, and dangerous drug-drug or drug-disease interactions, which often manifest nonspecifically as confusion or false. This all compromises the resident's safety and overall quality of life. My proactive approach to preventing adverse drug events, ADEs, is rooted in thorough assessment and interdisciplinary collaboration. To illustrate, I once admitted a new resident, Mr. Davies, who was taking 10 different medications prescribed by multiple specialists situation. My immediate task was to identify potential high-risk medications and reconcile his complete medication list, guided by the principle of start low, go slow, and seeking to minimize the pill burden. My action involved using the Beers criteria to screen his medications for potentially inappropriate medications, PIMS, in the elderly. I then collaborated with a prescribing physician and the pharmacist to conduct a comprehensive medication reconciliation and deprescribing review. We identified a benzodiazepine for sleep and 2 separate medications for mild hypertension, both of which were contributing to his reported daytime drowsiness and dizziness. We successfully phased out the benzodiazepine and consolidated his hypertension treatment. The result was a reduction from 10 to 7 medications. More importantly, Mr. Davies reported significantly less dizziness, his mental clarity improved, and his risk of falling due to medication side effects was substantially decreased, demonstrating a direct improvement in his safety and well-being.
Explain the importance of the minimum data set, MDS, and the care planning process in a long-term care setting.
The minimum data set, or MDS, is not merely a bureaucratic requirement. It is the federally mandated clinical assessment tool that forms the entire foundational structure for resident care and resource allocation within a long-term care setting. Its importance spans clinical, financial, and quality domains. Clinically, the MDS is the comprehensive assessment that drives individualized care. It captures a vast array of information, including cognitive status, mood, functional abilities, skin integrity, and pain. This data is converted into specific resident profiles. This directly feeds into the care planning process, which is where that raw data is translated into actionable goals and nursing interventions. Without the accurate, timely completion of the MDS, the care plan is essentially irrelevant because it lacks the necessary information to address the resident's true needs. For example, if a resident, Ms. Johnson, scores high on the MDS section assessing her risk for falls and low on the section for mobility situation, the interdisciplinary team, IDT, has a clear task: create a goal of maintaining safe mobility while mitigating fall risk. The action within the care plan would then detail specific, measurable interventions, such as ensuring her physical therapy schedule is followed, using a bed alarm, providing non-slip footwear, and using a two-person assist for transfers. The result is a documented, legally defensible, and person-centered approach to care that ensures regulatory compliance. Furthermore, the aggregate MDS data is used by external agencies to calculate the facility's quality measures and determine appropriate reimbursement levels, underscoring its dual role in clinical excellence and financial viability.
How do you approach pain management for a resident with advanced cognitive impairment who cannot verbally express their pain level?
Managing pain in residents with advanced cognitive impairment who lack verbal communication is one of the most challenging, yet crucial, responsibilities in geriatric nursing, as unmanaged pain significantly decreases quality of life and can exacerbate behavioral symptoms. My approach relies on standardized, nonverbal assessment tools and a highly individualized, proactive schedule. The central challenge in this situation is the inability to use the standard 0 to 10 numeric rating scale. The task is to identify the presence, intensity, and cause of pain reliably and intervene before the resident expresses distress through disruptive behaviors. My action always begins with the use of an observational scale, such as the Pain Assessment in Advanced Dementia PAIN-AD scale. This tool focuses on 5 key domains: breathing, negative vocalization, facial expression, body language, and consolability. Observing changes like rapid breathing, moaning, grimacing, guarding a limb, or increased restlessness provides objective evidence of discomfort. Furthermore, I rely on proxy indicators and behavioral patterns. For example, a resident who is usually calm might suddenly exhibit sundowning behavior or resistance during routine care. Recognizing this as a potential pain manifestation, my action is to administer a scheduled analgesic, such as paracetamol, and then reevaluate the PAIN-AD score 30 minutes later. If the restlessness and guarding decrease after the medication, the result confirms that the behavior was pain-driven, allowing the care team to adjust the medication schedule to a preventative routine regimen rather than a reactive one. This proactive, observational, and evidence-based approach ensures that pain is consistently anticipated, identified, and managed, upholding the resident's right to comfort.
What measures do you prioritize to prevent the geriatric giants: immobility, instability, incontinence, and intellectual impairment?
Preventing the geriatric giants, immobility, instability, incontinence, and intellectual impairment, is the primary focus of proactive geriatric nursing, as these complex syndromes often lead to functional decline and loss of independence. My strategy prioritizes holistic, preventative measures rather than reactive treatment of complications. To address immobility and instability falls, my key measure is emphasizing ambulation and strength maintenance. I ensure that every resident's care plan includes scheduled walking or transferring, often collaborating directly with a physiotherapist. For instance, if Mrs. Chen was identified as sedentary situation, my task would be to increase her safe mobility without elevating fall risk. My action would involve ensuring she is assisted out of bed and into a chair during mealtimes, participating in chair exercises, and using appropriate assistive devices. The result is maintaining muscle tone and balance, which is the best defense against instability and subsequent falls. Regarding incontinence, I prioritize restorative measures over containment. This involves implementing a scheduled toileting program based on the resident's individual pattern, rather than simply relying on absorbent products. The goal is to maximize continence and dignity. Finally, preventing or slowing the decline in intellectual impairment involves robust cognitive stimulation. My approach is to ensure residents are engaged in meaningful activities and social interaction every day, moving beyond passive TV watching. This might involve running a reality orientation group or integrating reminiscence therapy into routine care. By systematically focusing on these proactive measures, mobility, continence, and stimulation, we not only manage the giants, but also actively support the resident's physical and psychological well-being.
Walk me through your protocol for a resident fall. How do you ensure this incident leads to systemic prevention changes?
Handling a resident fall is a critical process that extends far beyond immediate care, moving into systemic quality improvement. My protocol involves an immediate, methodical response followed by a mandatory investigative and reporting process, ensuring the incident drives preventative change. The immediate situation is finding a resident, Mr. Henderson, on the floor. My initial task is twofold: ensure his immediate safety and assess for injury. My action begins with a crucial step. Do not move the resident until a focused primary assessment is complete, unless he is in immediate danger. I would call for assistance immediately. I would check his vital signs, assess for consciousness, and perform a rapid head-to-toe check for obvious injury, paying particular attention to head, neck, and hip integrity. If an injury is suspected, I would follow an emergency protocol, immobilizing the suspected area and notifying the physician and family right away. If no injury is apparent, we use appropriate lifting equipment, such as a mechanical lift, to safely move him to bed. Full documentation of the event, the assessment, and all post-fall vital signs follows immediately. To drive systemic change, the incident then triggers an incident report and a post-fall huddle. The task of the team is to determine the root cause, which is rarely a single factor. My action involves reviewing the resident's chart for contributing factors. Was he wearing the right footwear? Was the environment cluttered? Had his medication changed recently, possibly causing dizziness? Was his call light in reach? This investigation ensures the fall is categorized. Was it accidental, predictable physiological, or unpredictable physiological? The result is a compulsory, updated care plan within 24 hours. For example, if the cause was reaching for a misplaced item, the change is to move the item closer and install a sensor mat. This process transforms the fall from a simple event into a valuable data point that continuously strengthens the facility's safety culture.
How do you incorporate a resident's personal history and preferences into their daily care routine to maintain their dignity and autonomy?
Incorporating a resident's personal history and preferences is the essence of person-centered care, directly supporting their dignity and autonomy, rather than treating them as objects of standardized institutional routine. This approach moves beyond basic medical care to honor the individual life they have lived. My primary method for achieving this is through comprehensive life history gathering and consistent interdisciplinary sharing. For example, during an initial assessment, I learned that Mrs. Kelly, a new resident with moderate dementia, had been a professional baker who always woke early and detested being served breakfast in bed. The standardized unit schedule, however, mandated late-morning bathing and in-bed breakfast service. Recognizing that forcing the standard routine would cause distress and resistance, I needed to adapt the care plan. My action was to collaborate immediately with the healthcare assistant and the activities team. First, I ensured her personalized care plan detailed her preferred 6:30 a.m. waking time and her desire to eat breakfast at the dining room table, not in bed. Second, I introduced a purposeful activity, involving Mrs. Kelly in preparing the breakfast trolley, even if only wiping down a counter, immediately after she was dressed. This action tapped into her baker identity and provided meaningful structure to her mornings. The result was a notable decrease in her morning agitation and resistance during dressing, and an increase in her meal consumption and social interaction. By leveraging her past profession and respecting her waking time preference, we transformed a potential conflict point into a moment of dignity and self-direction, proving that flexibility and routine is fundamental to genuine person-centered care.
Describe your understanding of unnecessary physical or chemical restraints. When might a chemical restraint be justified, and what steps must be followed?
Unnecessary physical or chemical restraints are interventions used for the sole convenience of staff rather than for the resident's immediate clinical necessity, and they constitute a violation of basic human rights and regulatory compliance. A physical restraint is any manual method or physical device attached to or adjacent to the resident's body that restricts freedom of movement or normal access to one's body. A chemical restraint refers to any drug used to manage a resident's behavior that is not required to treat the resident's medical symptoms. A chemical restraint is only justified when there is a documented, acute, and persistent danger to the resident or others, and all less restrictive measures have failed. It must never be used as punishment, coercion, or staff convenience. The necessary steps that must be strictly followed when considering a chemical restraint are meticulous. First, an exhaustive assessment of the situation must be conducted to identify the cause of the dangerous behavior. Is it pain, fear, thirst, a UTI, or an adverse drug event? My task is to exhaust all non-pharmacological interventions, such as redirection, environmental modification, or meeting unmet needs. If these fail and the resident's agitation presents a clear danger, the action requires a physician's order with specific, limited duration, and explicit indication. Importantly, the chemical restraint policy mandates a concurrent review of the behavior management plan, continuous monitoring of the resident, and a plan to gradually reduce the dosage and discontinue the medication at the earliest possible time. The result is that the resident's immediate danger is mitigated while ensuring the use of the drug remains a temporary measure of last resort, ethically protecting the resident's rights and preventing arbitrary pharmacological control.
What steps do you take to manage and de-escalate aggressive or agitated behavior in a resident with dementia?
Managing and de-escalating aggressive or agitated behavior in a resident with dementia requires a systematic, compassionate, and investigative approach, often referred to as responsive behaviors management. The key is to recognize that the behavior is communication, indicating an unmet physical or psychological need. My first step is to treat the behavior as a clinical puzzle. I always attempt to use the DICE approach: describe, investigate, create, and evaluate. For example, I encountered a resident, Mr. Smith, who regularly began yelling and striking out at staff during his 4 p.m. dressing change. The task was to safely de-escalate the behavior in the moment and then investigate the underlying cause to prevent recurrence. My immediate action was de-escalation. I approached him calmly, used a soft, low tone, maintained a non-threatening posture, and gave him ample personal space. I avoided arguing or confronting his reality. I used redirection by placing a familiar object in his hands, such as a well-worn book, to engage his attention. Once the immediate crisis passed, the investigative phase began. We reviewed his chart, suspecting pain or discomfort. It was discovered that the 4 p.m. dressing change coincided with the wearing off of his morning analgesic dose. The action to prevent future occurrences involved adjusting his medication schedule to ensure coverage during that critical time, and modifying the environment by having his wife record a comforting message to play during the change. The result was the elimination of the aggressive behavior during the 4 p.m. routine. This proves that managing agitation effectively relies on finding the underlying cause, validating the resident's feelings, and adjusting the care plan, not just managing the outward symptoms. How do you educate a resident or their family on end-of-life care options, and what is your role in ensuring their advance directives are honored? Educating residents and families about end-of-life care is a delicate, continuous process centered on communication, respect, and clarifying goals of care. My role as a nurse is primarily one of an advocate and educator, bridging the gap between medical terminology and the family's emotional and spiritual needs. The process often starts with the advance directives being reviewed, which is a key nursing responsibility. I recall a situation where Mr. Harris, who had end-stage heart failure, was confused about his living will, and his daughter was hesitant to discuss hospice care. My task was to clarify his options, explain the difference between curative and palliative care, and ensure his written wishes were understood and respected by everyone. My action began by scheduling a calm, private meeting with both Mr. Harris and his daughter. I did not initiate the medical discussion. Instead, I started by asking about Mr. Harris's priorities, what mattered most to him in the coming months. This person-centered approach shifted the focus from death to living well. I then explained the various end-of-life options, clearly outlining that palliative care focuses on comfort and symptom management and is often delivered through a hospice program. I used simple language to explain that his advance directive, his voice, was the legal document guiding our team. I ensure that all terms, such as do not resuscitate, DNR, or do not intubate, DNI, were fully understood, not just acknowledged. I documented the conversation thoroughly and immediately communicated the clarified wishes to the interdisciplinary team. The result was that Mr. Harris and his daughter chose to transition to hospice care, leading to better pain control and emotional support. By acting as the bridge between his medical orders and his personal values, I ensured his autonomy was honored, and his final days were focused on comfort and dignity, as per his stated wishes.
Describe a time you had to deliver difficult news to a family member regarding a resident's decline. How did you handle the conversation?
Delivering difficult news requires immense sensitivity, transparency, and a structured approach to ensure the family member feels supported and informed, not overwhelmed. I utilize a process rooted in empathy and clarity, focusing on what the news means for the resident's quality of life. I recall a situation involving Mr. Chavez, a resident with advanced Parkinson's disease and dementia, whose swallowing function had significantly deteriorated following a recent chest infection. The specialist's recommendation was to cease oral feeding due to high aspiration risk and switch entirely to comfort measures. The task was to communicate this difficult news to his son, who was struggling to accept the decline. My action followed a clear protocol. First, I ensured privacy and adequate time for the discussion, sitting down at the same level as the son. I began by establishing his current understanding, asking, "What is your understanding of your father's condition right now?" This allowed me to assess his emotional state and knowledge base. I then presented the information directly but compassionately, using simple, non-technical language. "I have difficult news regarding your father's ability to eat safely. We found his swallowing has become too weak, and continuing to feed him puts him at very high risk of pneumonia." I paused frequently to allow him to process the information, addressing his emotions before moving to clinical details. Finally, I focused the discussion on the new goal, maximizing comfort and dignity through meticulous mouth care and symptom management. I outlined the immediate next steps and ensured the hospice or palliative care team would follow up with him. The result was that while heartbroken, the son appreciated the honesty and felt he was an active partner in the shift to comfort care. This empathetic and structured communication honored his role and respected Mr. Chavez's final stage of life.
How do you ensure effective communication during shift change, handoff report, to prevent gaps in care for your residents?
Effective communication during shift change, or the handoff report, is perhaps the most crucial process for maintaining continuity of care and preventing errors in a 24/7 nursing environment. I strictly adhere to a standardized, structured format, typically using the ISBAR framework: identify, situation, background, assessment, and recommendation. This structure ensures all critical information is efficiently and concisely transferred. I recall a situation where a resident, Ms. Adams, was being transferred from my night shift care to the morning shift. The task was to communicate every change, even subtle ones, that occur during the night to prevent a care gap. My action utilized ISBAR to focus the report. I would identify myself and the resident. The situation would focus on the last 4 hours. Ms. Adams was restless from 0400 to 0500 but settled after repositioning. The background briefly summarizes her baseline. She is post-hip replacement, high fall risk, and has stage 2 pressure ulcer on her coccyx. The crucial part is the assessment. The pressure ulcer dressing was changed at 0600. The wound bed looks pink, but there is slightly increased serous drainage. Her vital signs are stable, but she refused her 0800 medication, stating she felt nauseous. Finally, the recommendation provides the action plan. Please follow up with a physician regarding the nausea and reattempt the medication with food at 1000. Also, ensure the wound dressing is checked again before lunchtime. The result of using ISBAR is twofold. First, it forces the outgoing nurse to summarize and prioritize, ensuring no detail is missed. Second, it compels the incoming nurse to listen for the explicit recommendations, leading to immediate, evidence-based follow-up actions. This standardized, focused communication protocol eliminates guesswork and dramatically reduces the potential for delayed treatments or missed changes in condition.
Explain your role within the interdisciplinary team, IDT, and how you collaborate with staff like physiotherapists or dietitians.
My role within the interdisciplinary team, IDT, is that of the central coordinator, advocate, and primary information conduit. In the long-term care setting, the nurse is the professional who has the most continuous, 24-hour contact with the resident, making us indispensable for integrating and evaluating the care prescribed by every other team member. We are the ones who translate the specialist plan into daily bedside practice. Collaboration is essential to make the IDT function effectively. For example, if a resident, Ms. Patel, had a recent stroke and was experiencing weight loss, the team would include the physician, the dietitian, and the physiotherapist. The task for the IDT is to ensure she maintains adequate nutrition while regaining mobility, and my job is to coordinate these efforts and monitor their impact. My action with the dietitian involves communicating her refusal of specific foods, noting consumption patterns, and observing for swallowing difficulties at mealtimes. I provide the on-the-ground data necessary for the dietitian to modify the texture or nutrient density of her meals. Similarly, with a physiotherapist, my role is to reinforce their therapeutic goals during routine care. If the therapist is working on stand pivot transfers, I ensure every staff member uses that exact technique and device for toileting and transferring throughout the day. I report back on her tolerance for therapy, any pain experienced, and her compliance. The result of this constant two-way communication is a unified approach. The resident's nutritional risks are mitigated promptly, and her rehabilitative goals are supported consistently, accelerating her progress and ensuring her safety across all shifts. This coordinated effort prevents conflicting instructions and ensures that the resident receives truly holistic care.
Describe a challenging conflict you had with a coworker regarding a resident's care. How did you resolve it professionally?
Challenging conflicts regarding resident care are inevitable, but they must be resolved professionally and immediately, always prioritizing the resident's safety. The key is to address the issue directly, focus on the facts, and avoid personalizing the disagreement. I once encountered a situation where an evening shift colleague, Sarah, expressed frustration and unilaterally stopped applying the medicated ear drops to Ms. Davies, who was on antibiotic treatment for an outer ear infection. Sarah believed the drops were irritating the resident and stated, "The doctor's order is clearly making the infection worse, so I'm holding the drops." My task was to uphold the physician's prescribed care plan, ensure the ear infection was appropriately treated, and address the coworker's clinical decision-making. My action was to pull Sarah aside immediately to a private area. I started by validating her concern. "I appreciate you noticing that Ms. Davies might be uncomfortable, as patient comfort is our priority. However, I professionally asserted the protocol. While you have a valid observation, stopping a prescribed antibiotic treatment without a physician's order constitutes holding a critical treatment. We cannot deviate from the order. That action places Ms. Davies at risk." I redirected her focus to the correct process. We agreed that the immediate action was for her to resume the drops, and I would contact the physician first thing in the morning to report the observed irritation and request a review of the type of ear drop or an alternative regimen. The result was the immediate restoration of the prescribed care. Sarah gained understanding of the boundaries of autonomous nursing action versus deviation from orders, and the physician subsequently confirmed the order but approved a switch to a less viscous drop, ensuring Ms. Davies' comfort was maintained without compromising the infection treatment.
How do you handle a situation where a resident makes an accusation of abuse against a staff member?
Handling an accusation of abuse is the most serious and non-negotiable situation in a nursing home, requiring an immediate, standardized response governed by strict regulatory protocols. There is zero tolerance for abuse, and the safety and protection of the resident are paramount. The situation is a resident, Mr. Jones, tells me that his healthcare assistant, Sarah, was rough with him during a transfer. My immediate task is to follow the facility's mandated abuse reporting policy, which overrides all other routine duties. This policy demands both the protection of the alleged victim and the preservation of evidence. My action involves several rapid steps. First, I would ensure Mr. Jones is safe, comfortable, and away from the alleged abuser. Second, I would clinically assess Mr. Jones privately for any physical evidence of abuse, such as bruising or skin tears, meticulously documenting his exact statement, location of injury, and the time the complaint was made. Third, I would notify the nursing director and the administrator immediately, as reporting mandates dictate that such allegations must be reported to the state's regulatory body, e.g., the state survey agency, within 2 hours of the initial complaint. Critically, the alleged staff member Sarah will be placed on immediate administrative leave pending the outcome of the internal and external investigation. This is a non-negotiable safety measure. My role is strictly limited to gathering the facts and ensuring proper reporting. I do not conduct the investigation itself. The result of following this strict protocol is twofold. Mr. Jones is immediately protected and assured of safety, and the facility maintains legal compliance, demonstrating a commitment to transparency and resident protection by initiating a formal, impartial investigation.
What does ageism look like in a healthcare setting, and how do you ensure your language and practice challenge age-related stereotypes?
Ageism in healthcare manifests as stereotyping, prejudice, or discrimination against individuals based on their chronological age, and it is a subtle but pervasive barrier to high-quality geriatric care. In a nursing home setting, ageism often appears as the assumption that an older adult's symptoms, such as fatigue, confusion, or lack of social interest, are simply normal aging, rather than signs of a treatable illness. This can lead to underdiagnosis and undertreatment. Other examples include speaking to an elderly person in a condescending elder speak, or making decisions for them without their input, stripping them of autonomy. To challenge age-related stereotypes, I ensure my language and practice are rooted in individualized assessment and empowerment. I consciously avoid using infantilizing language and always address residents with respect, using their preferred title. Clinically, I ensure every reported symptom is investigated. For example, if a resident reports fatigue, I don't dismiss it as old age. I investigate potential causes like anemia, thyroid dysfunction, or depression. My commitment to anti-ageist practice is built on supporting autonomy. I ensure that whenever possible, the resident is the primary decision-maker in their care, even if it involves minor decisions. For instance, when asking Mrs. Thompson about her morning routine, I ask, "Would you like your hair washed before or after your breakfast?" rather than telling her, "We're washing your hair now." This respects her time and personhood. Furthermore, I actively highlight resident achievements and life experiences, celebrating their roles as former professionals, parents, or artists. By treating every resident as a complex individual with unique capabilities and preferences, I ensure my practice reflects dignity and respect, actively dismantling ageist assumptions in the care environment.
Tell me about a time you identified a flaw in a nursing home policy or procedure. What did you do about it?
Identifying a flaw in policy demonstrates a commitment to safety that goes beyond routine adherence, showing critical thinking about resident outcomes. I recall a situation where our standardized wound care policy mandated weekly dressing changes for chronic pressure ulcers, regardless of the wound characteristics. We had a resident, Mr. Henderson, with a difficult-to-heal stage 3 sacral ulcer. The task was to follow policy, but I observed that the highly absorbent silver dressing we were using often had to be entirely peeled back during dressing changes, causing him significant pain and delaying the healing process due to unnecessary disturbance to the fragile tissue bed. My action was to first consult with a wound care specialist to confirm my suspicion that the weekly change interval was inappropriate for this specific dressing type, which was designed to be left in place for up to 7 days or until strike-through occurred. Once the specialist confirmed that the current policy was causing harm due to premature changes, my second action was to write a detailed report for the Quality Improvement Committee. I presented the evidence, referencing best practice guidelines that advocate for less frequent dressing changes for certain advanced dressings to promote an undisturbed moist wound healing environment. I proposed a revision to the facility's generalized policy, recommending an exception clause that allows the registered nurse, in consultation with the wound specialist, to extend the dressing change interval to a maximum of 7 days based on the specific dressing type and wound condition. The result was that the QI committee adopted the policy revision, which led to a standardized decrease in pain for residents and, importantly, a documented improvement in the healing rate for chronic wounds across the unit, demonstrating that challenging an outdated policy can directly enhance patient care standards.
Why did you choose geriatric nursing, and what qualities do you believe are essential for success in this field?
I chose geriatric nursing because I believe it represents the pinnacle of complex, compassionate nursing care. Unlike other fields focused on acute, short-term recovery, geriatric nursing focuses on the quality of the remaining years, demanding comprehensive management of multiple chronic conditions, advanced psychological support, and ethical advocacy. I find deep professional satisfaction in translating complex medical goals into daily routines that enhance a resident's comfort and dignity, rather than simply extending their life with minimal regard for quality. The essential qualities for success in this field go beyond clinical skill. They include patience and empathy, because cognitive impairment often requires nurses to understand distress without relying on verbal cues, investigative curiosity, To recognize that a change in behavior or status is always a symptom of a treatable underlying problem, not just old age, and most critically, advocacy. The geriatric nurse must be a fierce advocate for resident rights, ensuring autonomy is preserved and that family and physician wishes do not override the resident's own comfort preferences, particularly at the end of life. Ultimately, I see it as a privilege to care for this population. It requires the ability to see the whole person, their life history, their values, and their current limitations, and integrate all of that into a truly person-centered care plan. My commitment is to ensure the final chapter of a resident's life is lived with the maximum possible comfort and purpose.
How do you manage the emotional burden of caring for residents in decline or at the end of life to prevent compassion fatigue?
Managing the emotional burden and preventing compassion fatigue in geriatric nursing is vital, as we are repeatedly exposed to loss, chronic decline, and suffering. My strategy for this relies on strong professional boundaries, self-awareness, and team-based support systems. First and foremost, I practice situational detachment while maintaining empathy. This means I connect deeply with the residents' feelings, their sadness, pain, or fear. I separate my professional identity from the need to personally solve or prevent the inevitable outcome of aging or illness. I recognize the difference between caring for a person and taking on the burden of their decline. For instance, when a resident with dementia is nearing their end of life, I focus my energy entirely on meticulous symptom management and ensuring their environment is peaceful, not on emotional rescue. Secondly, I utilize structured peer support and debriefing. I recall a situation where 3 beloved residents passed away in a single week, leading to palpable sadness and low morale among the evening staff. The task was to process the grief and reaffirm our purpose to prevent burnout. My action was to initiate an informal compassion check-in with my colleagues after the shift change. We spent 10 minutes privately acknowledging the loss, sharing a positive memory of each resident, and simply validating the difficulty of the week. This ritualized acknowledgement prevents feelings from being suppressed. The result is a stronger, more resilient team, where emotional experiences are normalized and shared, rather than carried alone. By consciously setting boundaries, engaging in self-care outside of work, and actively utilizing peer support, I ensure that my compassion remains renewable, allowing me to provide high-quality, sensitive care consistently.
Describe your approach to continuous professional development relevant to aging and chronic illness management.
My approach to continuous professional development, CPD, in geriatric nursing is dynamic and targeted, recognizing that the evidence base for chronic illness management and aging is constantly evolving. I don't view CPD as simply earning required hours. I see it as a cyclical process of identifying a knowledge gap, applying new learning, and then evaluating the improvement in resident outcomes. The core of my approach focuses on 2 areas: evidence-based practice for common geriatric syndromes and regulatory compliance updates. For example, knowing that chronic pain management is a central issue, I recently completed specialized training on the use of non-pharmacological interventions and assessment tools like the PAIN-ADS scale for nonverbal residents. This specific training allowed me to immediately implement more holistic pain management strategies on my unit. A recent situation where I applied this continuous development was following a facility audit that highlighted an issue with medication interactions. The task was to enhance my knowledge of polypharmacy management in older adults. My action involved seeking out an accredited online module focused on the Beers criteria and deprescribing principles. This learning confirmed the necessity of proactively consulting with a pharmacist on all new admissions and any time a resident exhibits unexplained lethargy. The result has been a more rigorous and critical approach to medication reconciliation, which directly translates to safer care for residents and reduced risk of adverse drug events. I also make it a point to attend interdisciplinary conferences focused on dementia care and end-of-life ethics, ensuring my knowledge base remains robust and aligned with international standards.